some sort of cervical cancer screening method. A very close lookup of this is the conventional IR spatula, which we used to do before, which I think is slowly being phased out. And when you prepare slides for people who still do the conventional method, you can put both the ectocervical and the endocervical in a single slide. We spray it with 95% ethyl alcohol. You hold the spray a little at a distance, just so that you don't disrupt the cells and you don't wash it off completely. And this is how we used to spray it, put the specimen onto the slide. So when we use the liquid-based cytology, currently what do? Do a speculum exam, you examine the cervix, you put in the brush, rotate it, and then the head will just get dislodged. You can just put it into the fixative and then send it off. That is all that is required. And yes, there is no increase in pickup of CIN2 or more if you use either a conventional cytology or a liquid-based cytology. But the pathologists are very happy because it reduces the number of unsatisfactory smears. So it doesn't matter what you do, it's important you do it. Now, so many times, you put a speculum in, you're not able to visualize the cervix, especially when you're just starting out on your career. You're not able to visualize the cervix. The best thing is, do a single finger examination, see whether you can feel the cervix. Sometimes the cervix is high up just behind the symphysis pubis. Sometimes it can be low down. When you just do a very gentle exam, you'll know exactly where to place your speculum. Now, if you make the examination painful, that lady is not going to come back to another gynecologist, another healthcare professional for a Papsmear. So it's up to you to make sure. Actually, when we do our MRCOG, one of the things they always tell us is, you have to look at the woman's face when you're doing an examination. If she winces, you fail the exam. So it's very, very important that you look at the woman to make sure your examination is comfortable. Based on how good your examination is, you are deciding the fate of that woman, whether she's going to go back for another examination or not. So very, very important, take time to make that woman in front of you comfortable. So we do this, abduct the legs. Sometimes you also say, put your hands behind the sacrum, abduct your sacrum to see if you can see it better. Always ask, has she had a hysterectomy? There have been women who've had a hysterectomy, and when we put in the speculum to see the cervix, they've had a subtotal hysterectomy. Clinical examination does not replace any technology whatsoever. A speculum examination is absolutely mandatory. And sometimes the cervix will be just flush with the wall. So what you can do is you just feel. A vagina feels very soft. However flush the cervix is, it will feel firm. So that will tell you where exactly you have to put your speculum in. And if the cervix is tenos, sometimes you can just hold it with a tenaculum or an alice. See if you can pull it a little bit forward. And in situations like this, a lithotomy will be of help. If she comes to you during a period, I would say I don't defer the test just because she's on a period. Day 1, day 2 on a period, unless she's bleeding profusely, I would go ahead. Remember, she's come to you with a problem. She may not come back to you again. If you're using LBC, the blood will get, it'll just settle down. It does not really make a difference. So please go ahead, do it even if there is going to be, and this is research based. So 23% during menses and versus 2% on the other days. But it's fine, it can be unsatisfying, but don't lose that opportunity to screen that woman. Can we use a gel or not? Previously, I think we were very cruel. We used to just use this unlubricated speculate just to make sure that we were, and yes, conventional cytology had its own problems. But if you can use cytology, you can use gel, put it a little bit on the anterior and the posterior lip of the speculum, and you do a gentle examination. There is no problem with getting a good result. LBC has taken care so much of our problems at all. So it really does not matter what test you use. Less unsatisfactory smears with LBC. So, but I think we should just go ahead and do it. There is some sort of quality control. Pathologists will tell us they have to go back to 10% of their negative smears to make sure QC is in control. So any test is only as good as the QC, and this is important. And that's one reason I feel India might not be able to go ahead with a cytology-based program, because in our country QC is so very difficult to find out. Now the other thing, of course, doesn't work. Screening in resource-poor countries, what can we do? So we have more than enough evidence from Dr. Shankar Narayan from his studies in India to show that whatever test you do, it will work. If you can do an HPV test, that is very, very good. That is the current WHO recommendation. Remember, it is more expensive than a PAP, but how does it offset? How is it offset? if you are HPV negative, you're working in a hospital, you're working in a private practice, HPV is negative, that woman comes back to you in 5 years' time. That is how the cost is offset, because the screening interval is increased. Whereas if you do a PAP, it's 3 years. If it's HPV, it's 5 years. And actually, if you're working in the community, the WHO says 2 tests in a lifetime is enough. So that is where the advantage of having an HPV test is. Yes, viability, but the problem with viability is quality control is very, very important. So what I might call negative, somebody else might call positive, and repeated training is required. Actually, when we did in our own community program, when we did VIA, we found almost 15 to 16 women and 100 women were VIA positive. It's very, very difficult getting all these women to come back for follow-up. While we switched to HPV, we found only 5 to 6 were positive. So that is the advantage of VIA versus, the advantage of HPV over VIA. So yes, we cannot always say cost is a factor. We have to move to be able to give better quality control to our better. Yes, so VIA is effective, but I don't think VIA perhaps may become a quality method of the past. If there is no other thing that is available, please go ahead and do VIA. In low resource countries, it's absolutely fine. In government hospitals, if you don't have PAP or HPV, please go ahead with the VIA. So yes, HPV testing. What are the advantages? It's objective. It doesn't depend on people. You take the test, you put it in the machine is going to tell you whether this lady is positive or not. It is reproducible. And yes, as Dr. Sarita rightly mentioned, we don't do co-testing anymore because WHO has taken it off from its screening pathway. And this was a study from Dr. Sankar Narayan who showed a 50% reduction in advanced stage 2 cancers and in cancer mortality by using a single HPV test as well. So what do we do with the screen positive women? Colposcopy. It's very, very important because I think all of us have to learn how to do a colposcopy. If you don't know how to do something, it becomes very difficult. If you know how to do something, it becomes very simple. So please, to the youngster, learn how to do colposcopy. It is not rocket science. You have colposcopy courses happening all across the country. Learn to do it. And hysterectomy is not the answer. We see so many women who've had a hysterectomy and who come back with a wart cancer. Hysterectomy is not the answer. Likewise, just adding another comment about imaging. When malignancy goes on to the vagina, even an MRI will not be given. So CA cervix 2A is a clinical diagnosis because you see that the fornices are involved. MRI will not be given. Nothing will replace a clinical examination and a spectral examination. I think this is very, very important, and I would strongly suggest that all of you have a colposcopy course. So this I think is very important. Little drops of water make a mighty ocean. One single step for a man, but a huge leap for mankind. And that is where all of us are. We are all working towards the 70% reduction, 70% of women to be screened in 2030. We don't have much time. I think all of us have to do our bit. So we cannot refuse to do something that we can do. It is up to all of us to make sure that we can screen every woman who comes to our clinic. So I'm just going to play. That I think is the essence of my talk. But what I will do is, I will also very briefly play a video on PAP and HPV.
Two tests are used to screen for cervical cancer, the PAP test and